Yeah,
Let's move
thank
on
you.
to the last case. This is going to be presented by Kristen Hare. Kristen really has been the heart and soul of the UW-FLS and bone health optimization program now for many years. And this is an abbreviation of the presentation that was an oral presentation at ASBMR on cyclic romosozumab in the clinic. Kristen?
Thank you. So this is a clinical case series, so a little bit different. I won't do too much background. We all know that we don't have a lot of osteoporosis drugs down the pipeline, so novel mechanisms and novel treatment sequences make sense. So we hypothesized that a short course of romosozumab followed by denosumab could help with a cyclical approach to build additional bone over time. And that was based on the fact that the P1NP rises very quickly with romosozumab, but returns to baseline by month 3. So the bone building action is already waning early. Same with CTX, suppressed early and then stays below baseline. So we implemented a protocol after detailed counseling with our patients of using 6 monthly doses of romosozumab followed by a dose of denosumab, and then checking the bone density and then repeating that sequence. And this is a cohort of about 41 patients, and we tried to make sure that they were similar to, frame entry criteria, so we could at least use that as a reference. It's not a research study, so there's no control group here. So the protocol was 6 monthly doses of romosozumab followed by denosumab, bone mineral density, and then repeat the sequence and do the DEXA again at year 2. And we did all of the review ourselves and read the bone density ourselves. So the patients are a standard osteoporosis cohort, 70-year-old female, pretty normal BMI, low bone density. And since we do fracture liaison service, most of these patients had fractures and many of them multiple fractures, but they were treatment naive or had not had bisphosphonate for several years. So what we saw, the dotted lines or the solid lines are our therapy. The dotted lines are the reference from frame. So with 6 months of romosozumab followed by denosumab compared to 12 monthly doses of romosozumab, we saw the same bone mineral density increases at the spine, hip, and femur neck. And then only a small number of patients have completed that second cycle at this point. So that's about 11 patients. We do see additional further increase that looks similar to patients who had 12 monthly doses of romosozumab and then 2 doses of denosumab to get to their 2 years. But the increase was blunted. It was only about half as big as the initial year. We also saw significant increases in trabecular bone score at year 1. And not everybody has TBS because they don't all have their DEXA on our system. So that was about 32 patients. And then the second year was a pretty low number. So perhaps trending improved, but hard to know for sure with a small n. And perhaps this is the reason for the blunted response in the second cycle. Again, this is clinical practice, so not everybody has CTX data because their insurance companies don't all cover it. But we had 6 patients who had a pre-treatment CTX, a pre-denosumab number 1 CTX, and then a pre-Romo cycle 2 CTX. And as you can see by that, 6 months post denosumab first dose, they're all suppressed. Their CTXs were all below 100. So perhaps they didn't respond as well to the second cycle because there's a carryover effect suppression. Very well tolerated. All the doses were given. Nobody stopped because of side effects. So in summary, we do feel that 6 monthly doses of romosozumab followed by denosumab provided significant increases. And for patients that, that's all we can give, that's, a nice cost savings for the same increase in bone mineral density, about half as much as 12 monthly doses of romosozumab. And we've changed our approach a little bit, and we're giving a free period where we're waiting for that CTX to start to rebound after that 1 dose of denosumab before giving the second cycle to see if we can get a bigger increase with that round 2 for patients that are able to continue. And this was a joint effort with our whole clinic. It wasn't just one person, so it wouldn't have been possible without them. Thank you.
Thanks, Kristen. Questions, comments?
Well, people should know that this paper was chosen as one of the clinical highlights from the ASBMR. So congratulations to Kristen et al. On that. And It'll be interesting to see. What I thought was interesting is the TPS looked a little better. Now, I don't know if those are just little, I mean, is that may not be much, but maybe when you get a bigger number, maybe I mean, be interesting if you end up with an actual difference.
Yeah,
Am I overreading that or not?
I think all of the anabolic data that I've seen indicates that the group TBS change is not as robust as the group BMD change, spine BMD change. Um, I think monitoring with TBS is a challenge, period. And the error bars on those graphs were pretty large.
Yeah.
Maybe if we do get a bigger number, maybe we can see something there. I think it's unfortunate that apparently nobody's going to do a real clinical trial. The 6 month and one DMAB was something that we thought could be implemented in the real world, and in fact, our nurses did it really well. But could you propose 2 months or 3 months? And could you propose a different anti-resorber, et cetera, et cetera, et cetera? Could you propose half-dose DMAB? I think there's a lot of potential options. And I think we're not going to be getting uh, a real placebo-controlled RCT to speak to that.
So
Uh,
how about 6 months to save money, one DMAB, and then ZA, which is, I mean, that may be a pretty inexpensive and extremely safe because you're only given one dose of DMAB. Your risk for rebound is extremely low. And I don't know if it's true in your place, but in our place, ZA total cost is less than a quarter of the cost of DMAB.
Oh yeah, it is definitely. And I have several patients who have done that. They didn't want to go on to a second sequence for some reason or another. So we did, give them a dose of Zola and check their bone density a year later. And we do continue to see additional increases
That's
in their
good news.
bone density. So that definitely works as well. Like I said, a lot of patients are like, I can commit to 1 year. If they have Medicare Advantage plans, they're paying like $2,500 for this treatment sequence. So we see these great increases and they're like, all right, let's move on. And then we give them the ZA and they do
So
great.
how can I kind of ask? I'm having a huge problem with Advantage plans and Evenity.
Yeah,
Um,
it's very expensive. They have to pay $250 to $600 a dose.
okay, that's our experience too. Okay.
Hmm. Yep.
Uh, I just there's a uh
And there's a very high cap. Like patients don't realize sometimes they're out of pocket of $6,000 to $8,000 before. Yeah.
so I
So.
mean 6 months saves them a lot of money.
Mhm.
If I,
and something that I've wondered about is so Joel, it's cool. We'll give 6 months of Romo or 3 months or 4 months, however many months, and then we'll give a DMAB, and then we'll shut the deal down with Zol. And we still have patients where we've taken them from a T-score of -4 to a -3, and their Hounsfield units are still 60, and they're still breaking. Um, should we follow Romo with anything? Should we be giving 3 months of Romo and taking 3 months off and doing it again and doing it again and doing it again? It's this blunting of the anabolic response that's beaten us.
yeah, I don't know, but if you prove that that works, then we should do it. Um, I'm worried that in the 3 months off, you might lose a substantial amount of the gain. And the the response after bisphosphonate is not as blunted as it is after DMAB. That's pretty clear that you get a better response to Evenity after bisphosphonate than you do after DMAB. So I like I could see this. Of course, I'm making up stuff kind of just like you were, but
Yeah.
I
Yeah.
could see given 6 months of Evenity, one DMAB, one dose of ZA, then waiting until the CTX gets above, say, 300 in 2 years, and give him another 6 months of Evenity. But yeah, I mean, I'm just making something up.
Yeah, we need to
Uh,
study. We need real research studies,
We need studies, but who's going to do that? It's not to anyone's advantage to do that,
except the patient.
except the patient.
And to
And
us, I think.
to us, but I mean, it's not to. No one probably even would want to. I don't think any company would say that this is an investigator-initiated study. We're going to support it. I don't see why they would.
I know for a fact they won't.
Yeah. So I mean, let's be honest. Um, Romo is a really good drug. They have it approved for a year. They just as soon every patient took it a year and get their year's worth now before there's a biosimilar in 5.
Yep. Well,
But you
And
don't,
solve that.
what's in it for them? What's in it for them?
can I just ask, this is just a moment. Can't you just like for your patients anyway, you could like use the 6 months and then reserve the next 6 months and just do something in between?
Yeah,
No?
and I mean, we have 50 or 60 more patients that have just done 6 months of Evenity, and then they did something else like oral alendronate or just one dose of ZA, and they come back every year, and their bone density is staying nice and stable. They maintain their 6 and 12% gain very nicely. So then, yeah, once they've been off ZA for
Yeah.
2, 3, 4 years, then go back to it again, and then I would expect to get another 6 to 12% increase once that wearing off. So yeah, we'll see.